Let us begin our discussion with a case. A 45-year-old male patient with a 3-year history of gastroesophageal reflux disease presents to the gastroenterology clinic with the chief complaint of increasing heartburn and regurgitation after meals. He has been taking antacids and proton pump inhibitors daily for the past 1 year with a reasonable relief of symptoms. Now, recently, the severity of the symptoms increased in terms of heartburn and regurgitation even with antacid use. You as a gastroenterologist perform an endoscopy and find orange gastric type epithelium extending upward from the stomach into the distal esophagus in a circumferential fashion. Now you take a biopsy and send it to the laboratory for histologic studies, but you fear that the man is now has an increased risk of developing esophageal adenocarcinoma. I hope you know what is the case. In this session, we are going to discuss about the Barrett's esophagus. So here, the etiology or the complication of the Barrett's esophagus is chronic gastroesophageal reflux disease. So the most common cause is long-standing gastroesophageal reflux disease, or we can say uncontrolled gastroesophageal reflux disease or the severe gastroesophageal reflux disease. So generally, if you see the gastroesophageal junction, this is the gastroesophageal junction. At the gastroesophageal junction, one will find Z lines. These Z lines are also called as squamocolumnar junction. The squamocolumnar junction is the junction between the esophagus and the stomach. If the Z line elevated towards the distal end of the esophagus, elevation of the Z lines to the distal end of the esophagus, as you can see in this picture, you can say that there will be a columnar epithelium which is extending to the distal end of the esophagus, right? Generally, esophagus is lined with the squamous epithelium. Squamous type. The squamous type of epithelium is converted into the columnar type, which is the gastric type of epithelium at the distal end of the esophagus. Reason is continuous irritation of the distal end of the esophagus because of the regurgitant contents from the stomach causes Barrett's esophagus. That is the reason I am saying that the long-standing GERD, uncontrolled GERD patients or severe GERD patients will develop Barrett's esophagus. That is the reason in the case they gave as orange gastric type epithelium. This orange gastric type epithelium, what you can see in this picture, is the columnar epithelium. So squamous epithelium is converted into columnar epithelium. So orange gastric type epithelium extending upwards from the stomach to the distal tubular esophagus in a tongue-like or circumferential fashion on the endoscopy findings or the hallmark of Barrett's esophagus. Now, what we will see, the microscopic findings in this. Squamous epithelium of esophagus is replaced by metaplastic columnar epithelium. This is the hallmark of Barrett's esophagus, metaplastic columnar epithelium with the mucosal glands containing goblet cells, columnar cells, and also some of the inflammatory cells which may be seen at this area, and they may display the signs of dysplasia, that is enlarged hyperchromatic nuclei. So now let us see what are the clinical symptoms which are seen in the Barrett's esophagus. So clinical symptoms are mainly due to the consequence of gastroesophageal reflux disease that is the history of heartburn, that is retrosternal burning, and manifestations, regurgitation, and belching after meals is one of the prominent feature one may see, and dysphagia is more commonly seen in the patient suffering from Barrett's. And what are the complications? The complications are extremely important over here. The complications include ulcers, that is ulceration, stricture formation, and one of the important complication over here is the development of esophageal adenocarcinoma, that is 30 to 40 fold increased risk of esophageal adenocarcinoma. So esophageal adenocarcinoma will develop in the Barrett's esophagus. So finally, what is the treatment we will give in this condition? The treatment is long-term proton pump inhibitors or H2 receptor antagonists and antacids are the treatment of choice. This is what you need to know about the Barrett's esophagus.